So good afternoon, everyone. Thank you for joining us for today's webinar on medication adherence, supporting wellness through medication adherence. We're very happy to be joined today by LaToya Logan, who is the presenter for today's psychoeducation program. Just a few notes. I will make sure you receive the slides from today's presentation in an email that you can expect to receive later today. This webinar, as was said before, is being recorded and it will be posted to the NAMI Greater Cleveland YouTube channel by the end of this week. And I will also ask you to complete an evaluation, put the link to the survey in the chat for you when we finish with our final Q&A at the end of the hour with this webinar. Just a few words about us. NAMI Greater Cleveland is a National Alliance on Mental Illness. Our mission is dedicated to improving quality of life for individuals living with mental health conditions and their families. And we do that by providing education, support, information and referral, and advocacy. You can always attend any of our support groups, and you're welcome to join us for any of the free and open to the public webinars or in-person educational programs that we offer. Please do remember to remain muted during the presentation. You can use the chat feature if you have questions while LaToya is presenting. She and I will both be monitoring the chat during the presentation so we can answer your questions while she is presenting, and we'll also have a few minutes for Q&A before we end. Thank you so much for joining us, and I will hand it off to LaToya to carry us through this webinar. Thank you for being here.
Well, thank you. Well, good morning. Happy Monday. I don't know where all of you are, but here in Cleveland, it's a little cloudy and rainy. So I thank you for joining me today. It's so interesting how things happen. I just got 2 messages from 2 former students who are in the webinar, so that's awesome. Today, we're talking about medication adherence, and really what that means is we're talking about recovery and wellness. So I'm really excited to present today because I know you know that if our clients can truly have hope that the medication they're taking is going to have a profound impact and not just helping them to reach some level of stability, but truly allowing them to thrive, then we get to do our jobs and we get to really see those positive outcomes that we're looking for. Thank you, Matt and Nami, for hosting this. Uh-oh, my audio is going in and out?
No, I think, Marilyn, that may be an issue on your end. We are hearing you loud and clear, LaToya. You're good.
Okay, awesome. And I do, if you've noticed at the bottom of the screen, it's kind of everything I'm saying is putting the words up there. So if you do have any difficulty, please look there and I'll do my best to make sure that I'm enunciating. So let's get started. So why this topic? Well, as you know, when anytime a client comes,
Is anybody else having this issue?
No, I think it's just you. You may want to restart, you may want to exit the meeting, rejoin, or investigate your device. Thank you.
Oh, my son is on this too. That's great. He's hearing loud and clear, he says. Okay, I just don't know what it is. I have all the, all my things saying the audio is fine, but okay, I'll do the best I can, and I'm
you
glad.
Can always listen. You can listen to the recording later. Thank you.
Yes, I will do that.
Okay. Thank you. And sorry about that. As you know, many clients come to seek services when they're in crisis. And when they're in crisis, I think we kind of have a knee-jerk reaction to immediately try to stabilize, to get information to help to support that person in recovering from that crisis. And we sometimes push medication in a way that isn't really helpful for long-term usage and understanding of why we're doing this. And so this topic, again, isn't just about medication. It's to help us understand different ways of education, engagement around medication, and then, of course, supporting the families. As you notice, this training is called medication adherence and not compliance. Compliance has a negative connotation because what we're saying to a person is we have set an expectation or a goal, and we need for you to comply with our expectation or our goals. And that is really anti the recovery model that we utilize to support clients. Our goals are to work with clients. And sometimes that might mean that we're going to suggest medication, but that doesn't mean that we're going to force medication. Research tells us that anytime we are talking about you must, clients are likely to check out because they're going to retain some sense of agency and autonomy. So adherence to medication is really about per definition, adherence to medication regimen is the extent to which patients take medications as prescribed by their healthcare providers to promote safety and improved health outcomes. Now, we already know most people don't take medication as prescribed because we are psychic at times. And so when we start to feel better 3 days into the 7-day medication, we go, oh, I must be okay, and I don't need to take it anymore. And so we all kind of struggle with wanting to take medications for long periods of time. So there are 3 types of adherence. The first is full-on adherence. This is where a person is taking 80% of the medication as prescribed. Now, I know you probably are thinking full and 80% doesn't amount to 100%. And the reason it doesn't is because we know through research, most people are not 100% in adherence to the medication and to be taking it as it is prescribed. Whether they're missing doses, whether they're taking it at different times of the day, whether sometimes they're doubling up on doses because they missed a dose or because they think it'll help with their symptoms, we know that it's never really 100%. The second type of adherence is called partial adherence, and that's when they're taking the medication 50% of the time as recommended or prescribed. And then finally, non-adherence is being off medications for 1 week. So partial adherence, when we're looking at the comparison to non-adherence, is really saying maybe they're taking their medication 4 days out of the 7 days of the week. That's partial adherence. They obviously have some insight that it has some benefit to it, but for whatever reasons are not 100% or at least getting to that 80% full compliance. Being off medication for 1 week is a decision. And we know that it isn't necessarily, I don't want meds, but it's a decision to not take medication for a week, because without taking that medication for a week, we know that symptoms can return and sometimes more difficult. So the impact of non-adherence, we know that non-adherence takes nearly 125,000 lives every year. People miss dosages, which means that they might enter in psychosis, which means they might enter into a medical distress or crisis situation. And it costs us about $300 billion a year. Because every time you go off of medication, we're kind of starting not from the beginning, we're starting at a deficit. When you're on and off medication, your body can build tolerance. So that means we might have to explore other medications because you're not responding anymore. We might have to up the dosage. So there's so much work that goes into really helping the person restabilize once they've gone off of medication. And then, of course, the hospitalizations that sometimes accompany that non-adherence. Non-adherence has terrible outcomes. The first is relapse. We know that if you're struggling with severe panic attacks or anxiety, that when you're off that medication, those intrusive thoughts might really pile on. And then that can lead to panic attacks. That can lead to really unhealthy decision making. And that can sometimes include suicidality amongst other issues. There are delays in achieving remission. So again, every time you go off of medication, to get back to that baseline of functioning, we're going to have to work a little bit more, and that might include additional medications or increase in the amount. Increased social impairment, job loss, difficulties within the families, arguments, conflict, and homelessness. We see an increase of incarceration. I mean, research tells us that nearly 50%, and that number is up and down, of incarcerated individuals have a diagnosable mental health condition. And we know that individuals who have mental health instability and unwellness are at greater risk for incarceration for a whole host of reasons. Self-harm, and this could be overuse of alcohol, this could be high-risk sexual behaviors, this could be drug use, it could actually be physical harm to self as well. Suicidality, because we're not stabilized anymore. And then, of course, premature death. So we're considering adverse experiences. Non-adherence is an adverse experience because it really does eliminate the progress that this person has made over time. Once we get them back and we're trying to re-engage them into services, there's a need to provide really high doses of medication because we don't really know at what level they are functioning at. So it could be severe where they are in full-blown psychosis, they are threatening to harm themselves or harm another person. And the amount of medication needed to stabilize that person is usually more than they would ever be taking as a regimented daily dose. Misdiagnosis is also an outcome of poor medication adherence because when you're off medication, you're not able at the time usually to articulate what your history is, really what your symptoms are, how those symptoms are impairing your functioning or just your thought process. And so we have to then kind of go back to the beginning and tease out, well, what medication is going to work? We also know that medication is complex. So what worked before may not work now. And if you aren't willing to accept new medication or try different things, it can lead to more long-term instability. So we're looking at the number of medications a person is prescribed, the frequency of that dosing, and how those two intersect to impact medication adherence. When someone is being prescribed 3 or 4 medications, and this can happen, because you can have a medical condition and a mental health condition requiring medication. And so it's very easy to mix up that medication or to feel as though you're taking too much medication. And some people have a fear of being dependent on medication for their life. And medication complexity is about misdiagnosing because patients' lack of an adequate response to the medication. So we typically are like giving medications for PRN. So every 15 minutes, if you're experiencing a panic attack, if maybe you're experiencing heightened sensibility to delusions, or you're experiencing a manic episode, you may be prescribed a PRN. A PRN might be something that's going to calm you down. Well, if you're not taking the regular prescribed medication as prescribed, meaning every day or twice a day, then you're going to become over-reliant on that PRN medication, which doesn't really help us in diagnosing what the actual issues are, because that individual would be in a state of crisis. And when you're in a state of crisis, it's very difficult to assess what is just normal baseline functioning versus what is being impacted by their frustration tolerance, by the number of symptoms they're experiencing, and the severity of those symptoms. So one example is, if we assume our clients are taking medication as prescribed, but they are still presenting with a lot of symptoms, or are presenting that are causing impairment, then we might offer an additional medication because we're not thinking that the initial medication is working, which means this person is going to be over medicated because we're not really addressing the issue. We're working off of the assumption that they are compliant. So we always want to make sure that we're asking the question, are you compliant? Risk factors for non-compliance include, or non-adherence include intolerable side effects. So I know we don't like to talk about this. We're like, just take the medication. It's going to eliminate the symptom that seems to be causing the majority of the impairment. But if we dismiss the impact of the side effects, then we lose buy-in from the person who has to take the medication. And there are times when the side effects are far worse than the symptoms they're presenting with. So that does require some collaboration and work with the client to see what can they actually tolerate, what can they actually live with in terms of symptoms versus side effects. It can result in unstable living conditions because the behavior could result in acting out. It could result in disturbing the neighbors and other people in the area, so they might be at risk for eviction more often, or they might actually be doing physical harm to where they live as a result of their psychosis or whatever other impairment they might be experiencing. Cognitive impairments. Some people report that when they take medication, they kind of feel like they're a zombie. They don't feel that they're aware. They're not processing information the same. And so they don't want to go through that. So they'd rather come off of the medication and at least feel as though they're a part of the world and not just kind of observing. Poor insight into need for treatment. So there are quite a few people who struggle with mental health issues who believe that this is just a part of their personality, it's a part of their life, and they don't believe treatment will assist. So part of our job is really making sure that we're building that insight and incorporating their concerns about treatment. Limited or family social supports. If you are trying to get into a routine for taking medication and you've never done this, or you've been inconsistent, you need a lot of family support to help just with organizing the medication sometimes, let alone, being motivated to take it every day. There can be a history of erratic or transient involvement in treatment services or substance use that can impact. So we're looking at dual diagnosing. If we're going to prescribe medications to clients, then we have to make sure we understand what are their coping skills? How often are they utilizing substances? Because that can definitely disrupt adherence to medication, and it can lead to other complications with taking the meds. And then finally, when we have an individual who has health and mental health issues that are complex, and so it becomes one of those things where, what medication do I take to create a sense of stability versus what's going to cause me to feel as though I'm kind of disconnected? So what leads to non-adherence? Well, money. Money is a huge factor in socioeconomics. It can be a barrier with accessing medication, or even really understanding how to utilize the medication. People who are, we give them this pamphlet and we say, here are the risks and this is why you want to take it. And we assume literacy, we assume comprehension, we assume understanding. And that can be a huge barrier in taking medications. Cost of meds. And I know a lot of clients will have Medicaid or have some form of insurance, but that doesn't necessarily mean that they can always pay those copays, or that they can purchase items that would support their compliance long term. Insurance coverage is a huge issue. Although many people can pursue Medicaid, not everyone is going to be eligible. We have a population of people who make just enough money to not be able to afford to pay for insurance, and also to be ineligible for Medicaid services. So we have to think about, when we're prescribing medications, what is the cost? What can we provide to support adherence, and what education is necessary to helping our clients? Transportation is a huge point too. There are some places that don't have drugstores in their neighborhoods. They don't have transportation. So getting across town to get the medication could be a problem as well. Unstable living situations where maybe they're living with someone who abuses substances, or takes medication or throws medication away. If they are transient or homeless, they may not be able to keep up with their medication because they're packing up everything every day. So things kind of get lost. And poverty. So if I don't have a place to live and I don't have food that I'm supposed to eat when I take this medication, or I'm not in a safe environment, medication becomes the last thing I'm really worried about. I'm focusing more on, how can I secure security for myself? How can I secure safety for myself? There's a lot of stigma around medication. I work with a lot of clients who come in and the first thing they say, I don't have to take meds, do I? And so what that tells me isn't that they really have a strong opinion about medication. Is that they have a strong opinion about what taking medication will mean for them. And that's very different perspectives to try to tackle. If I'm just anti-meds, that's a whole nother conversation. But if I think taking meds will make me appear crazy or violates my personal beliefs in some way, then I'm going to be resistant to pursuing medication and certainly complying with it long term. So that's the first thing we want to think about, is what are their personal beliefs? What's their experience with taking medication? What are other beliefs that people have in their immediate circle about medication? We have to assess for the perceived benefits and risk. So can this person actually keep up with the regimen? What does the family believe about this medication being in their household? We tend to think that, it's medication and everybody is going to be okay. Like, yes, let's take it because it's going to work. But that isn't really the case in life. In life, people will push people away who are on meds, or make jokes that can be hurtful about taking medication. And then finally, what is the culture or spiritual beliefs connected to taking medication. If you're a practicing Rastafarian, then taking medication for something like a mental health or even medical conditions is not really something that's supported. So how do we work with their culture, their religious beliefs, and their spiritual beliefs, so that we are supporting the client, but also making the best decisions for their wellness? Adverse side effects of medication. Now, we've all taken medication and had a side effect. If you have to take antihistamines because of your allergies, then you know, even though it says non-drowsy, it's always drowsy. And it's always drowsy at the wrong time. So you try to get creative and you're like, I'm going to take it at night. And then unfortunately you wake up and you have that kind of disconnected feeling. So that's an adverse side effect when you're trying to treat something that is causing impairment in your life, because you can't go around sneezing, your eyes running. And unfortunately, you then have this side effect that slows you down the next day or has an impact on your ability to get things done. So this is true for all medications. There is some side effect that is probable, and how do we support them? So first things first, tell them the truth. We need to make sure that we're discussing all of the potential side effects. Now, I know there's this thing that says it's very low risk, these things can happen. And when we say that and we're like, that means I don't have to talk about it, then that is going to be the side effect that your client or your loved one is going to experience. So it's best to just kind of go over all of the potential side effects and have them keep like a journal or a log about what they're experiencing. Some of the most distressing side effects that we see that has an impact on individuals' interaction is weight gain. Many of these medications that we take that definitely can improve the quality of our life can also reduce the quality of life in other areas. If you are a person if you've ever taken steroids, then you know weight gain is a part of that. But if you have asthma, you kind of got to get through that Z-Pack. You might have to take long-term steroids in order to breathe and live every day. But then that means you're trying to balance this unnecessary weight gain that can not only impact just how your body is functioning, but your self-esteem, your ability to interact in the world, and it can result in isolation. Gastrointestinal problems is a huge issue. Not everyone has the best diet to begin with. And then when we're talking about medications that require food, then that can have really difficult impacts on us if we don't have food to eat at that time. Sexual dysfunction is a big one. Our clients want to enjoy pleasure as well. And sex is one of those things that provides pleasure. And so when that gets stripped away from a person who's already battling with self-esteem issues, stigma of having a mental or medical condition, and not really understanding what their identity is outside of that, then it can deepen depression. So now we're talking about sexual dysfunction that causes or at least exacerbates depression and anxiety. It can cause a flattening of affect where people feel kind of like blah. And I think I just mentioned that, where they feel kind of disconnected or zombie. Like my clients always talk about that. I don't want to feel like a zombie. Like I want to hear a joke and be able to laugh on time. And that is a real concern because we pick up social cues through nonverbals most likely. So if we're not able to engage in nonverbal expressions, then it can really impact our ability to socialize, build relationships, and maintain relationships. And finally, sleep disturbance. Now, I'm a person who has to be in the bed by 9. I just finished my last class at late night. I need to sleep, and that's just what has to happen. Now, imagine if you are dealing with a mental health issue or a medical issue, and then you take the medication for it and you can't sleep. You may have the capacity to function better, but when you don't have enough sleep, it impacts or impairs your functioning as well. So it's almost like a toss-up. Where do I get the impairment from? The lack of sleep or the symptoms that I'm experiencing? There are significant health disparities. A particular type, and this is defined as a particular type of health difference that is closely linked with socioeconomic and or environmental disadvantages. If you're in Cleveland, there's a great study that came out about 2 years ago, and it said that even in the city of Cleveland, where we have a lot of hospitals, if you are a person of color or an impoverished person, you can live directly across from a hospital, but still not feel safe to go there and seek assistance. And a lot of that is about potential judgment, that you fear you may experience, not really having yourself affirmed when you go, not being treated fairly. And so health disparities can be experienced based on racial ethnic groups, religion, social orientation, geography, and it is marked with discrimination or exclusion. So when we think about gender affirming services, if you have a mental health disorder and you're going in to seek services and you haven't legally changed your name, but you choose to go by the name that you're giving, but they don't call you that, or they don't acknowledge you by that name, they don't use pronouns, then you're least likely to seek out assistance, because the experience alone, never mind what you're dealing with, is creating more issues and more negative emotions. Health system inequity just exists. We've known this for years. There have been multiple reports released by SAMHSA, our Substance Abuse and Mental Health Services Administration, which is our federal oversight for behavioral health services. And they talk often about this lack of access, this lack of resources. So if you just think for a moment, what are some policies or procedures or practices in place that support medication adherence? What do you do if a client comes in? What do you do as a family member if you're saying, I'm really struggling with helping this person to remain in adherence with their medication? What support do you receive from those health systems? And you can unmute yourself and answer, or you can drop it in the chat. And you don't have to comment at all if you're not comfortable, but I'm going to give you about 30 seconds to kind of put information in if you want to. Besides exploring compliance. Thank you, Sarah. I was hoping somebody was going to say that. 100% true. A lot of the times, the only thing that we do is just say, you need to be compliant. Let's talk about how to get you compliant. And that doesn't necessarily address the medication adherence issue, because that means we're not really incorporating whatever barriers may be in place to really support this client. And it also suggests that the client doesn't want to adhere to their medication, which is often not the case. They're just making a tough decision between the information they have and the experiences they have had. So thank you. Excellent, excellent point. Clients can struggle with, yes, medication delivery would definitely help in removing some of those barriers. I agree 100%, 100%. So clients struggle with just difficulty accessing services, whether it's a limitation on public transportation, or they just don't have the finances to get to a place. Sometimes they don't understand really where they should go that would be a best fit for them. And that definitely plays a part too, and just like really educating them on resources. A lot of clients don't understand how to utilize their case managers to help them access additional resources. And a lot of clients may not necessarily know how to advocate for access, to say, I'm struggling in this area with accessing this resource or this medication. What can you help me with to support it? Because there are things that we are all, as systems and services, have to respond to. There may be delays in service availability, and I know you all have been experiencing this. The wait list for therapy, the wait list to see your PCP, it's so much. We are dealing with a reduction of workforce in healthcare in general. And so that's definitely having an impact on how quickly our clients can connect into services. And so we want to think about that when we're talking about adherence. We need to talk about whether or not the person was able to receive the service in order to get the next prescription. Because unfortunately, there still are some prescriptions that you have to get rewritten every 60 days, every 90 days. It can't just be refilled. Sometimes there is ineffective discharge coordination. I have worked in hospitals, and it's always interesting to me when a person is walking out of the hospital and we know they've been in crisis to some degree. And we say, okay, you have everything you need, take care. they're excited to get out of the hospital. Yes, they want to do well, but their first objective is, I've been in the hospital. How is my home? How are my things? How are the people that I care about? So really thinking about what they need to be successful with adhering to their medication is going to be difficult. This is why we need to think about, what can we put in place at discharge that isn't just a piece of paper saying, go get your medication or call us if you need help. I'm a huge fan of not telling clients to call if they need help. Most people struggle with asking for help. So part of our job as providers, as caregivers even, is to say, let's go over this again just in case, so that we're clear and we're on the same page. And then, of course, that feeds into poor communication strategies. Again, we assume literacy, we assume comprehension when we do that printout from the hospital and we give it to clients and we think, hey, they must understand what this is. Sometimes we just need to sit and really talk and make sure they understand how to separate their medications, really how to set their timers on their phones or their watches or wherever to take it. And thank you, Lanisha, that's a really good point. You had a pharmacy package your medication in the bubble bag so that it's organized. It was just too much for me to put in the pill planner myself every month. It has made adherence, but yes, because sometimes it's like, just help me. You know what to do. I'm struggling with what to do. Help me to organize this in a way that makes really good sense for me. So thank you for sharing that, because that's definitely a small little strategy that we can do to support adherence. Sometimes things are just illness related. We have impaired memory, concentration, or judgment. And that's going to be present for whether you have a medical condition or a mental health condition. You know, some of us who are anxiety ridden, keeping things straight and really remembering that beautiful list we wrote to remind us, that's hard enough, let alone trying to follow through on what we've put. Sometimes there's limited insight because you've been dealing with this for so long. You kind of are like, I think I can gauge when I'm not doing well. And we know that's the story we tell ourselves. There's difficulty with problem solving. And I think we should anticipate that. That doesn't mean that they're not engaged, they don't want to do it. It's just, I struggle with making good decisions in the moment. So I kind of put it off. There could be disorganized decision-making. I love procrastinators because they're like, no, when I'm under pressure, I work better. Yeah, but then it's too late. If you're working under pressure, that means that you're probably going to make a mistake just because you're rushing to get everything done. There sometimes is a lack of motivation. They've been on medications before. They've never gotten to a place they felt good. So how is this going to be any different? Low energy plays a role too. And that could be a side effect or the working with another medication to make you a little bit more tired. When you have an illness, you can be hypersensitive to stress. Your frustration tolerance is being challenged every single day because you have so much on your plate to try to manage. And it's very stressful to always live in fear that you're going to relapse, that you're going to return to the emergency room and have to start all over. And finally, substance use conditions. And substances don't have to be illicit drugs. Yes, it can be alcohol. It can be opioids or something to that degree, but it can also be over-the-counter medications. A lot of people rely on sleep aids that they purchase from like a CVS pharmacy or Rite Aid pharmacy instead of talking to their doctor about how this is contraindicated to take with their actual medication. And there are some people who take vitamins and herbs that they haven't disclosed to their primary care physician or their psychiatrist. And so there's some issues happening there. All right, it wants to be jazzy. There we go. So let's talk culture and medication adherence, because every single person has a culture. And our culture impacts what we believe about wellness, what we believe about mental health, what we believe about symptom expression, and certainly what we believe in terms of hope. How do we get better? When we don't include a person's culture, their belief system, their value system, their spiritual beliefs about what better looks like, and we're consistently relying on medication or even treatment that they may not necessarily believe in, then we're losing some ground and really developing a collaborative relationship. So we want to make sure that we're taking into consideration culture. We also want to make sure that we're paying attention to genetic differences. And this is an area that is new, but we're finding out has one of the biggest impacts on medication adherence. This is a big word, ethnopsychopharmacology. And basically what it means is taking medications for psychiatric distress based on your ethnicity or your race. What we know today is that ethnicity and culture influences an individual's response to medication, not just the way they think, but literally the genetic or psychosocial makeup of that person. So when we're seeing side effects, when we're seeing non-adherence, sometimes it's because the person is experiencing something in their body that they cannot articulate. They don't necessarily have the words for it. So on the other side of that is, how do we really educate people to listen to their bodies? In 2021, Dr. Higgins said, because minority groups are underrepresented in the drug development process, we need a clearer picture of how different medications may affect subsets of our populations. This is critical because when we're talking about efficacy or the positive outcomes of taking medication, we're always saying it's going to work. It's been proven in this study. Many of these studies have been done in a homogeneous group. And so it doesn't necessarily apply cross-culturally or cross-racially. Metabolism and over-medication is a huge component. We know that medication is based, or at least efficacy of medication is based on how it metabolizes in your body. Most medication is based on scientific research of metabolic occurrences in Europeans or Eurocentric bodies, genetic makeup. And so it's not really consistent across racial groups. We know that 33% of Black Americans and 37% of Asian Americans / Pacific Islanders are slow metabolizers of antipsychotic and antidepressant medications. What that means is that if you are a person of European descent and you are given a medication, a PRN, within 15 minutes, we expect for that PRN to start having an impact on that body. But if you are of Black American descent or Asian American / Pacific Islander descent, it may take you up to 45 minutes to have that medication actually metabolize and have a positive outcome on your symptoms. So what often happens is, because we're not seeing that 15-minute turnaround in these populations, then we give another PRN and we give another PRN and we're like, oh, okay, it takes 3 PRNs for this person to get better. That's not really true. It's just we're not waiting long enough for the body to metabolize that medication based on their genetic composition. This can lead to mistrust because you're over medicating me. I'm telling you something is not right. I'm telling you I don't feel good, but we're not listening to the clients because we're like, you just don't want to take the medication. It can have serious side effects. If someone only needs 10 milligrams of Ativan, but we've given them 30 milligrams, we have created some serious issues, not just in terms of the side effects, but their social functioning as a whole. And it can result in the development of new symptoms. So when we're giving excessive amounts of medication, we could be creating new symptoms that can definitely have greater impact or impairment on their lives. And it can result in inappropriate treatment and long-term disability. And we've seen this, we see this. And so we want to make sure we're questioning and we're challenging a bit. We also know that families and caregivers are overwhelmed just with managing a whole nother person's life and feeling responsible for their outcomes, both in their wellness and their life functioning. And this is not really something we can get around. The system doesn't have enough staff to really support every single person. So we do rely on families and caregivers to step up. Most patients who have a severe mental disorder and are discharged to their families. Families who can't engage or utilize restraints, families who don't really have the medical knowledge or skill set to intervene in sometimes the most healthiest ways. And so that can result in a burden related to that person's ability to recover and rehabilitate, because that family member has to supervise those medications. And what happens when the family members gets tired, or they have to go to work, or they are overwhelmed and they forget to do it because they're doing 15 other things? And unfortunately, it can result in deceptive tactics. So family members could say, you know what, you won't take this medication when I give it to you. So they start sneaking it in what they're drinking or what they're eating, or they're lying to them about what the medication is, or they're lying to them about the potential side effects because they're trying to get the person to adhere to the medication to support their wellness. So this then has an impact on the relationship between the family and the client. There's also comorbidity. So if we're taking this medication, we're not taking the medication, we're taking another medication, and we're constantly on and off, this can result in premature death. So our goal is to promote mental health literacy. That means, number one, we have to be able to recognize specific disorders and really help people articulate what they're experiencing, what they're going through, and their expression of those particular symptoms. We want to make sure that we're providing mental health information that is up to date. So there are so many changes that are consistently happening all the time. And those changes should inform how we're engaging and how we're supporting, definitely how we're prescribing medications. We want to look at risk factors of mental illness. We want clients and families to truly understand some of the risk factors associated with mental illness, whether that is victimization or that is instability due to limited finances and lack of employment. We want to talk about it when they are doing well, because then we can get buy-in about what strategies to use to sustain that. Knowledge of causes of mental illness. So some people, based on their spiritual beliefs or cultural beliefs, may believe that it's because they sinned or that they didn't do well enough. We want to make sure we're providing accurate information as to what can cause mental illness. I always tell my clients when they come and they're like, I think I'm crazy. I said, no, we all have a brain, which means we all have mental health, which means we all will experience some impairment at some point in our life. This is a normal experience. Just some people may have a longer bout with it or a more severe bout with it, but that means we should be providing support, not judgment. We want to talk about self-treatments, really understanding what that person believes can help. You know, are they into meditation? Do they believe that nature really matters? And how do we work with that belief system and the medication? We want to make sure that professional help is available. So I tell everyone, yes, 988 says suicide and crisis lifeline, but it really is for so much more than that. If you just need help, you want to question something, you want more information, call 988. You can get the information. If you don't want to talk to anybody because you're tired of talking to people and you just want your question asked, you can text 741-741 and get information that way too. We don't want anybody to feel as though they have to do it one way. And then finally, we want to make sure that we're addressing attitudes that promote recognition and appropriate help seeking. So every time someone takes their medication, we should be applauding them for that. Every time they maintain their appointments, we should be applauding them for that, because they could have chosen not to do that. It is difficult to stay the course of something that seems like it's never ending just to have stability in your life. So we want to make sure that we're promoting that. So how do we improve adherence? First things first, we have to focus on recovery goals. We don't set them. The person taking the medication tells us what matters most to them in terms of their recovery and their wellness. We have a hard time there sometimes because we want to push, well, don't you want a job? I don't think anybody wants a job. Like, who wants to work if they don't have to? That's not really a good caveat, right? But maybe it's, do you want healthy relationships? Do you want to live independently? Do you want to be free of this impairment? That may work better with supporting them. And it can be, maybe they just want to play the guitar again. To me, that's a sufficient goal that is rooted in recovery and wellness and will have a longer positive impact than us just saying, we think you should do this or that. We want to make sure that we avoid discussing symptom management unless the symptoms are the barrier to their recovery goal. So I have worked with clients diagnosed with schizophrenia. This one client I'm thinking of in particular did not take medication ever. He chose to live with the symptoms. He wanted some help with the anxiety and some of the paranoia, but he didn't mind having the hallucinations. So I can't say, well, don't you want to get rid of that? It didn't impair him. He functioned, he took care of his business, but it was his choice to decide what symptoms he felt he could live with and could not. we want to discuss the potential side effects. So before we add another medication, before a doctor wants to add another medication, talk about the side effects and talk about whether or not they are at full compliance or partial compliance with the original medication. Evaluate the impact of the side effects on their recovery goals. So if the side effects are going to result in sexual dysfunction or flat affect, and this is a person who's used to being more lively and bubbly, then we may have to think about some other medications or treatments in lieu of that medication to prevent non-adherence altogether. We want to assess the risk of side effects on adherence as well. So if the side effects are far greater than the functioning that they're desiring, we would have some issues there. Now, I often train on how important it is to have hope, but this isn't about the clients having hope. This is about providers and even family members having hope that their loved one or their client can get better. So we want to make sure we're communicating what we think is possible as a result of taking the medication, whether that's an improved affect, whether that's improved social relationships, maybe that's in them being able to actually fulfill a goal they've always had of working or going to school. We want to make sure we're communicating that we believe it's possible. We then want to make sure that we're looking at how this relationship exists. Number one factor for medication adherence is the clinician-patient relationship or the family-patient relationship. People want to believe that you believe that in them, but also that you're going to listen to them, that you're going to consider what their concerns are, and that you will incorporate those concerns in your decision-making. This is key to trust and caring. And if I don't trust you, then everything else you say is irrelevant. And so I won't even accept any care from you. So we have to make sure we're starting with the building block of, you can trust me. I'm going to tell you exactly what's going on. I'm going to tell you exactly what my concerns are, and I'm going to listen even more than I talk. We want to promote their decision-making. So a lot of it has to be questions. What would you like to do? Why don't you want to do this? What do you think may work better? What additional information do you need to feel more secure in taking this medication? We have to lead with hope. I'm a believer that recovery is possible and that treatment does work, but that only happens if we're collaborating. The teachable moment has to be, what can we learn from the non-adherence? So if they go off of medication, ask them, what did you learn from that? What did you like about it? What would you like to bring forward from that experience? And what do you want to avoid in the future? I know it can seem kind of odd to say what worked well with the non-adherence, but the reason that they're not adhering is because something is working, whether they feel like they're more fun, excuse me, or they feel that they're more social. It doesn't matter. It's up to them. If they're telling us that's something that I don't feel when I'm taking medication, then we have to incorporate that concern and try to support them. Interventions you can use, managing the common side effects. So maybe they experience more anxiety from taking the medication. So you may want to teach them some techniques or strategies that reduces the anxiety. Maybe there are some issues with sexual dysfunction. So maybe there's some things that can be incorporated to support healthier relationships sexually in whoever is their partnership. We wanted to make sure that we're working from a shared decision-making model. So if they say no to a medication, then we need to allow that to stand unless there is a risk to their actual life and harming themselves or someone else. Partner with the pharmacist. I'm a huge believer that if you take medication, talk to your pharmacist, because they're there in the store with you and they're seeing you from a different perspective and may be your biggest advocate in talking to your doctor about what the concerns are that you're bringing into the store. So if you please, encourage getting your medication from the same pharmacy so that you can build a relationship with the pharmacists who work in there. Consider some long-acting medications. Now, I know not everybody is a huge fan of the needles. I get that. They don't want to take a shot. But some of this is about really talking about, right now, it's going to be better for you to have the injection so that you don't have to stress about taking the medication every day. And the trade-off to that is once you get to a place where you're more stable, you have more insight, You can transition to pills if that works better for you. So again, always offering options. Nothing has to be permanent. Educating the client's family, friends, and support system. And support system is really important. Whoever they're saying are the people who rah-rah them and rally behind them and are invested in them is who we want in the room when we're talking about medication adherence and what things can work. Peer support specialists are a huge benefit because they can talk in a way that providers and families who aren't dealing with those issues may never be able to. They can share their own stories of the fears of taking medication, managing symptoms, dealing with the impairment, and how they chose to adhere to medication. And if at all possible, simplify the medication regimen. We shouldn't have someone needing to wake up and take a medication at 8 o'clock and then take 2 other pills at 10:30 and then another one at 3. We need to find a way where these things can work together. And if I'm taking my meds, and I'm taking the meds I have to take for the day and not needing to have multiple things to do in the day. Assessing medication adherence. So you're going to get this tool as well. This is just a question and answer. You would talk, if you're the family member, you can do this as well. And it's just really a conversation to find out where they're at, what is their thought process and what do they need. So it's 10 questions and the questions are yes or no. So we're just trying to get like, just in this moment, how do they feel about things, not long term. So the questions include, do you ever forget to take your medication? I mean, for me, I would say, yes, I do often. Are you careless at times about taking your medication? And you may want to qualify what careless means. Careless could be, I'm so busy taking care of somebody else that I don't think about taking care of myself, so I miss taking my medication. When you feel better, do you sometimes stop taking your medication? And this is why we're developing this antibiotic resistance, because people stop taking medications nearly halfway through because they feel better. Sometimes if you feel worse when you take the medication, do you stop taking it? So again, lifting up the fact that even though the medication will help in one regard, it may cause some issues in another. I take my medication only when I'm sick, and we see this, right? I'm in a crisis. Where's my medication? Oh, hopefully it'll help right now. And of course it won't. So then they go through the whole process again. And it's like, well, why would I take the medication? It didn't work when I needed it most. And so again, there's education there. It is unnatural for my mind and body to be controlled by medication. So this is the cultural, spiritual, or personal belief that we want to make sure we're incorporating. My thoughts are clear on medication. By staying on medication, I can prevent getting sick. I feel weird, like a zombie on medication. Medications make me feel tired and sluggish. And that's a major concern. No one wants to wake up and want to do a thing, but not have the energy to do so because of the medication they're taking. And there's one other one I want to show you, and then I'm going to open it up for questions. So give me 1 second, and you'll get this one as well. This is also a tool I use with my clients in assessing whether or not, whatever their thoughts may be about the medication. And I'm going to try to make it bigger. Okay, there we go. So this is the true or false. This is obviously more questions. It's 30 questions in total. And you get points for this, but it really helps us to see where we may need to make some changes or modify some things in some areas to support. This is not a tool I would say you need to use every single day. Instead, I would say this is a tool you might want to use every 30 days and then move it out to every 60 days based on where the person is making improvements or experiencing some deficits. So the first things first, I don't need to take medication once I feel better. This is going to assess for perception and beliefs about the use ongoing of medication. Even when I'm not in the hospital, I need medication regularly. So that helps us to understand whether or not they believe they have an illness or an injury. Medications make me feel more relaxed. Hopefully, if they're taking medications, it does. Number 10 is of particular importance, and sometimes we kind of shrug it off, but it really does matter. I am no different on or off medication. So maybe this is an opportunity to do some insight building from the family members, caregivers, or friends. We see a difference. This is what we notice when you're not taking medication versus when you are taking medication. You're more expressive. You actually listen to us. You engage with us. You go to work. whatever those things may be, we want to lift them up. I can't concentrate on anything when I'm taking medication. This could be a sign that they're on the wrong medication. It isn't always that the client is wrong, that the patient doesn't understand. It's that they could be 100% right, but we kind of get into this, well, the doctor told you to take it, it's going to work. That could be true, but we want to always make sure that we're listening to the client and incorporating what their concerns may be. And then, of course, one of my other ones that I really like to use. By staying on medications, I can prevent myself getting sick. This is written different. I can prevent. This is a strength-based question. Do they believe that they have the power to stay healthy, to stay well, to make good decisions if they take their medication? If they do, then that's going to be something that we're using at all times to make sure that we're encouraging the support and education for those clients. So I am going to stop sharing that one and go back to the PowerPoint for questions. And now's a great time. You can put them in the PowerPoint, in the chat, or you can unmute yourself and ask.
Any questions for LaToya before we end? I did also put the link to the survey for the evaluation for today's presentation in the chat. If you could all complete that for me before we end, that would be greatly appreciated. I actually have a question I would like to pose. Curious to know if others may be experiencing this. Do you have any thoughts on the circumstance in which we may interact with an individual who has strong personal beliefs around like alternative medicine and holistic health practices and a resistance to, you know, the medicalization, the medical model of taking meds? Do you have any thoughts on like approaching that conversation with someone?
Absolutely. There's, like I said, I do work with quite a few clients who are Rastafarian. And they're like, medication, no, it's poison. Don't put that kind of stuff, only things from nature. And I am reminded of Bob Marley. Bob Marley had cancer in his big toe and practicing Rastafarian and refused any treatment for it because he believed in prayer and the prayer would cure him of the cancer. And unfortunately, by the time he was ready to engage in treatment, he died of cancer that did not have to take his life. And so approaching that isn't about, see, your beliefs are wrong. It's tell me what you're willing to do based on your beliefs. What are you willing to accept is possible with medication or treatment? We are not going to force you to do anything that is inconsistent with your spiritual or cultural beliefs. What we want to do is be complementary. So if your belief is that your body is a temple and you can only put great things in it, well, let's talk about what some of those great things are. And let's look at the ingredients of some of the medication and let's see if we can get them to work together. I don't think we do enough of that because it does take a lot of time. That means that's a lot of education before you actually prescribe a med or do anything else. So I have good adherence with my clients. And I practice in Cleveland, Ohio. I have good adherence with them because I am open first to let's get all your questions answered. Let's address the fears you may have associated with taking medication. And then let's just pose a what if you took the medication and it had positive outcomes. I often tell clients too, needing to take medication right now doesn't mean you will need to take medication forever, and certainly not at the dosage you may need today. So a lot of it isn't just about pushing back. It's about saying, thank you for sharing that information. Let's incorporate that. Let's get a doctor in here. Let's get a nutritionist in here. Bring in your faith healer or whatever your practices or beliefs are, somebody, and let's talk about how we can collaborate to support your overall health. I do believe that sometimes providers are dismissive of holistic practices, which we now know are extremely effective. I mean, we talk about dialectical behavioral therapy or mindfulness, which is really a Buddhist practice. They've been doing that for forever. And we just caught on to the effectiveness of it. So definitely think we need to open those things up. Can we best help them? How can we? I'm sorry, the first part of this question cut off. Once they have decreased meds, are they falling into psychosis? How can we? So if that's another question, right? If they're taking medication and they want to decrease it, before we decrease it, we really want to speak to the doctor about why that dosage was prescribed to begin with. Why did we think that amount was needed? And if they really feel like I like to try to reduce it, then there's a step down process for that. It wouldn't go from you're taking this to you're taking nothing or you're taking half of it. A good psychiatrist should be stepping it down. So if we're at 100, let's go down to 80 and see if you still are able to function as healthy as you are right now. So that would be my advice. Anybody who's like, just go off of it, find another psychiatrist. Can you kindly expand some suggestions when you're healing? I'm not sick. I don't need. Oh, yeah, right. That's a great question. I would say they're not sick. That's what I say to my clients. When they say they're crazy, no, you're not. I'm just so sick. I can't. No, you're not. The stigma of being sick is the problem. Oh, no, I got you. I got you. It's the stigma that we're up against. So I would say you're 100% correct. You're not sick and you may not need medication forever. But what if we just tried medication for now to get you to a place where other therapeutic interventions might be able to help your healing, and then we can see about walking you back. I don't have a problem with the client saying I'm not sick, because I do think that they have a right to feel that way. We just have to work with it to support healing and wellness.
It looks like we are at 1 o'clock. I will just put the link to the survey again in the chat. Great content, great information, great questions. Again, you'll receive these slides later today, and you'll also be able to view the recording of the webinar on our YouTube channel. Just go to YouTube, type in NAMI Greater Cleveland, and you'll find our NAMI GC YouTube channel. We'll post that by the end of this week, so you can view it again later. Thanks so much, LaToya, and thank you all for joining us. Hope you have a great day.
Thank you all. Take care.